Good afternoon, everyone. It is proud privilege and pleasure to welcome each one of you who are being here with us today for this seminar. Today, we are fortunate to have eminent speakers from diverse backgrounds, and I feel delighted and honored to welcome all of them. I would like to specifically acknowledge the contribution of our partner and co-host, Indian Association of Respiratory Care. We could not have done it without you. Thank you for being with us, sir. First, give you a background of what IHD is, because before we address the seminar specific agenda, that's because it helps us to understand why we are here today and why we are conducting this particular seminar. So IHD is an enterprise committed for social impact. We were born in 2015 with the mission of helping in designing and delivering solution for sustainable development goals with two key approaches. One is the human-centered and second is the ecosystem partnership. We firmly believe in result-oriented engagement with various stakeholders in the value chain for achieving desired health outcomes. We are a team of professionals from diverse backgrounds, business management, policy and public health, epidemiology and biostatistics. And the third is social science, medical science, and legal and rights. Now, in the recent past, we exactly on the same day, 1 month before, in July 28th, we launched an Access to Care, our flagship program, which is an integrated, comprehensive, personalized patient care and doctor support services, addressing the three dimensions of access to healthcare. One is the financial accessibility, physical accessibility, and acceptability of healthcare across nine chronic diseases. And that's where we are coming from for this webinar today. Now I think the important thing which we have been realizing is about the COVID-19 pandemic, which it's a crisis in the century which we have faced, we are facing today. Now this COVID pandemic has made put our patient with COPD and other comorbidities at a higher risk for poor outcomes. And access to care is a key issue for our patient. Now, since the COPD causes more deaths in AIDS, TB, malaria, diabetes, etc., hence it becomes extremely important for us to deliberate, covering a wide range of access-related issues of diagnosis, treatment, management, while addressing what India requires now and what in future to tackle COPD. We are aware of the tremendous effort that many stakeholders are addressing in this space, but no matter how much we can do, we can try at national, global, national, regional, or local level. It never be enough. Whether it's a service delivery, it's an R&D, or capacity building initiatives. So this seminar is basically a response to recognizing the urgency of this issue and collaborates for understanding what is working well and why it is not working. If nothing is working, then why it is not working, while translating national strategic plan into concrete actions at grassroots level. So IHD and IARC both has decided to come together to deliberate and discuss on the action-oriented replicable efforts to solve the issue of why India is not responding adequate enough to the challenge of containing COPD. I think with this remark, I would like to share that it's a very overwhelming response which we received, and especially 50% of our registration, or the people who are watching us are the youngsters, the prospective leaders of the healthcare. And I would like to just give a message to them that we have been hearing that whether we are going to give certificate, what we are going to get from attending the seminar. So the one message which I want to give to all of them, that getting certificate or not getting certificate is not important. Important is whether you are utilizing the opportunity which you are getting to learn or to change the life. I think that's the way one should think about it. And remember, great things will never come sitting in the comfort zone or sitting in your own self, motivation or self intent. You have to think about, patients first and human centered first. That's where the healthcare professionals should think about. So with this message, now I would like to invite Ms. Madhura, who is the Vice President of Indian Association of Respiratory Care, and I'm really pleased to work with her, and it's been a great association so far. So I would like to request her to formally, launch this program and start the sessions. So over to you, Ms. Madhura. Can you please go ahead with it? So Madhura has, I think, some connectivity issues. She is not available here. So then I would really request Dr. Sandeep Salvi, who is there, who's a session moderator and who's an eminent expert. And I think he doesn't need any introduction. Everyone knows in healthcare sector in this field. So I'll request Dr. Sandeep if you can, start the session with your opening remarks. Thank you.
Sure. Thank you. Thank you very much, Dr. Ruchi, for a wonderful introduction. Wish you all a very good evening, and greetings from IIPH for this very important session on chronic obstructive pulmonary disease. I believe Dr. Madhura is just about to log in.
Hello.
So if she's joined in, I think Madhura, you can start. Dr. Ruchi for a wonderful introduction. Wish you all a very good evening.
Yeah, Madhura, can you start? We didn't see you, that's why we requested Dr. Salvi to start. So can you please start now?
I believe
So Ms. Madhura, are you able to hear us?
Madhura, do you want to start?
I think she has connectivity issue, I guess, Dr. Salvi.
Okay. So then once again, wish you all a very good evening, and welcome to this very important session on chronic obstructive pulmonary disease. I would at the outset like to express my very sincere thanks to IIPH for hosting this meeting in partnership with Indian Association of Respiratory Care, and I really look forward to moderating this important event in the midst of such eminent faculty that will follow the presentation. I hope you all can see my presentation. Just if anybody could say yes, then I can carry on.
I can't see.
Can you see my presentation?
No. I can't see, Sandeep. Can't see.
Okay.
Sandeep,
okay. I will.
You have to share your slide. I think we are not able.
I will try it again. Okay. Is this okay now?
Yes.
Okay.
Yes.
Okay. So
yeah.
So I bring to you greetings from my institute called Pulmocare Research and Education Pure Foundation from Pune city. That's where I'm based with a team of very exciting people working on the field of asthma and COPD. What I'm going to cover over the next 10 minutes or so is just a brief overview about the silent epidemic of COPD in India and why India needs a national COPD prevention and control program. So I'm going to focus on this, and I'm going to set the scene for the remaining 4 speakers to deliberate on various topics and thought processes with regard to the COPD problem in our country. Obstructive pulmonary disease, or popularly called as COPD, is a chronic progressive disease of the lung that is currently the second leading cause of death and the second leading cause of disability adjusted life years in India. What you can see on the slide over here is how a healthy lung looks like on the left hand side and how a COPD lung looks on the right hand side. You can appreciate that there are big differences between a healthy lung and a COPD lung. You can see that the lung has become big in size, and that is largely because of air trapping, or what we call as hyperinflation, because of alveolar wall destruction and obstruction of these small airways. In addition to that, you see the black color that seems to have seeped in every corner of the lung, and that is because of the toxic pollutants, including the smoke or the tobacco smoke, that has entered into these lungs over a long period of time. You would also appreciate that between the two lungs is the heart, and if you look at the size of the heart in the patients of COPD, the heart obviously looks big in size, and that is one of the important characteristic features of COPD. It is a disease that not only affects the lungs, but it affects a whole host of other organs as well, primarily involving the cardiovascular system as well. COPD gives rise to a heart disease, and that also contributes to the suffering and the death that is associated with this disease. COPD, although not very well known in our community, amongst the lay people or perhaps even amongst healthcare providers, was a term that was in 1966, after a lot of deliberation and a lot of debate and fight between the British and American physicians, who had earlier called it as chronic bronchitis and emphysema. The British were refusing to give up the name of chronic bronchitis, and the Americans were refusing to give the name of emphysema. So, in 1966, a wise called William Briscoe brought all the Americans and the British together, and he said, "It is because of fight that the disease is not getting global recognition. So let us all come together and give it a common term that the whole world will accept." And that was the genesis of the word COPD, which the word itself includes a disease that affects the windpipes as well as the lung parenchyma. And for those of you all who want to understand what a normal lung looks like, here is an image of the bronchial tree that I've just inverted to make it look like a tree. And you can see the branching pattern of the airways. The main stump that you see here is a trachea, then the right main bronchus and the left main bronchus. And those yellow circles that you see are the alveoli, where the oxygen diffuses into the blood circulation. And that's the main purpose of the lung. So the normal human lung, normal healthy human lung, has about 40,000 such branches in the both the lungs, and those pink circles, which are called as alveoli, there are a total of around 600 million of these spread across both the lungs. Uh, Everyone breathes in about 10,000 liters of air, out of which the lungs soak in about 1,000 liters and pass it on to the circulatory system, from where it is transported to different organs. So I show you what an image of a normal healthy lung looks like. And in contrast to that, here is another image, which on the left hand side shows you what a healthy lung looks like, and on the right hand side, what a COPD lung actually looks like. The two predominant changes that you should appreciate in this is that the branch pattern or the number of branches have become less, which means that there is disappearance of the airways in the lung of COPD patients, especially the small airways. And you can also alveoli have reduced in size, and they're filled with black colored, toxic pollutants that have been deposited over a period of time. So this is a wonderful image that was drawn by one of my colleagues at the Pure Foundation, which actually shows in a very simple art form what actually happens in patients with COPD. Tobacco smoking was identified as the first and perhaps the most important risk factor for COPD. And in fact, for about 40 to 50 years, was almost equated to smoker's lung, because it was believed to be the most important risk factor that was driving COPD. In our country, tobacco smoking is not as popular as in the Western world, but nonetheless, we have about 120 million people who smoke tobacco. But there is a difference over here. 70% of the people who smoke tobacco, they smoke bidis, and bidis are very different from cigarettes in terms of the risk for developing COPD, and that is because of the large amount of tar that is present in the bidi smoke. Therefore, one BD is almost equal to 5 cigarettes in terms of the content. And therefore, Indian people who smoke BDs are at a greater risk of developing COPD. Then you have the the chillum, which is another way of tobacco smoking in some parts of the country, especially in the western part of India, the northwestern part of India. And you can see that the chillum is actually a lot more harmful than either the bidi or the cigarette because of the quantum of smoke that enters inside the lung, and also the composition of the smoke, which causes more harm than than the nicotine leaves that most people inhale. Hookah smoking is becoming more popular in our country, especially in the bigger cities and towns. And people are also led to believe that the smoke that passes through water actually cleans and purifies the smoke. And therefore, the smoke that you inhale inside your lungs is actually clean and does not cause any harmful effects. Uh, but that is not very true at all, because research that has been conducted very recently has shown that hookah smoking is even worse than cigarette smoking. In fact, one session of 25 minutes of hookah smoking is equated to about smoking 100 cigarettes in terms of the quantum of pollutants that enter inside the lung. So clearly, I think although cigarette smoking is perhaps identified as an important form of tobacco smoking, but in our country, there are other forms of tobacco smoking which are perhaps more harmful than cigarette smoking in regards to the risk of developing COPD. Uh, 10 years ago, I was invited to write a review for the Lancet on COPD and non-smokers. And that was the first time that we actually highlighted the fact that we do not need to be a smoker to develop COPD, especially people living in the poorer parts of the world, where non-smoking factors are more important than tobacco smoking. And this is the data that I have derived from the Global Burden of Disease, published in 2018 and 19. And this study suggests that globally, 65% of the COPD occurs in people who have never smoked in their life. And therefore, the burden of non-smoking COPD is a lot more common than what we knew until that point of time. What is more important is, in a country like India, 80% of the COPD occurs among people who have never smoked in their life. And I think it's important for us to appreciate that, both as clinicians, healthcare providers, as well as policymakers, because if COPD is not, 80% of COPD is not caused by tobacco smoking, then it is important to understand the other risk factors that give rise to the development of COPD so that relevant policy decisions could be taken. What you see over here is a global map in different color codes. The sky blue color represents the high socio-demographic index countries, or the rich countries, and the red colored countries, which is the low socio-demographic index countries, are the poorer countries. And you can see that India is green, which is the middle socio-demographic index country. And from the left to the right, as you go, these pie charts, you can see that in the high socio-demographic index countries, such as the United States or Europe, 72% of the COPD is attributed to tobacco smoking. And as you go to the poorer countries, the contribution of tobacco smoking becomes less and less and less, and non-smoking risk factors then become more important. And these non-smoking factors include ambient air pollution or household air pollution, or even occupational exposures. So in a country like India, household air pollution and ambient air pollution are the major drivers of COPD than tobacco smoking. And here is just some pictures that depict the risk factors for COPD in India. 50% of homes in India still continue to use biomass fuel, especially in the rural areas. And the smoke that comes out from the burning of this is largely responsible for causing COPD in the rural population. As I said, 120 million smokers, so that's also an important risk factor for COPD in India, nonetheless. Then you have ambient air pollution. You know the levels of air pollution that occur in the cities of Delhi, Kanpur, Chennai. Very high levels of ambient air pollution that drive COPD. Occupational exposures such as farming, road sweeping, building and construction, the exposures are associated with that. We know that burning mosquito coil produces as much amount of pollution that is equal to smoking 100 cigarettes during that one night. That is also an important risk factor for COPD. Then you have other indoor air pollutants such as dhoop agarbattis. One dhoop agarbatti is equal to 500 cigarettes in terms of the particle pollution that it produces. Agarbattis, use of pesticide sprays, previous history of pulmonary tuberculosis is also identified as an important risk factor for COPD. Previously undiagnosed, poorly treated chronic asthma is also an important risk factor for COPD. And then other occupations such as the pujaris who are smoke on a regular basis. So India is a country that has got a whole host of different risk factors that are associated with COPD, not necessarily only tobacco smoking. I was fortunate enough to be the chair of the chronic respiratory disease section for the Global Burden of Disease India report. And we published this report a couple of years ago in the Lancet Global Health. This is perhaps the most authentic source of information related to COPD in our country. India has estimated 55 million cases of COPD. We rank number one in the world for that. We rank number one in the world for disability-adjusted life years associated with COPD. And we rank second in the world when it comes to the number of deaths that are associated with COPD. So clearly, the burden of COPD in India is very huge, and it is only growing with time. Comparison of COPD deaths versus some of the other important diseases that have huge health impact, like AIDS or TB or malaria or diabetes. Even when you put other diseases together, COPD is responsible for causing more number of deaths than all together. I think it's important for us to start appreciating this problem before it gets out of hand. This is the heat map of India in 1990 on the left-hand side, 2006 on the right-hand side. Show you the changing patterns of COPD across different states in India. You can see that the colors are becoming more red and darker in shade. The burden of COPD has been increasing or has increased over the years, which is also very important for us to appreciate. When we look at the global burden of disease report and look at the number of COPD cases vis-a-vis other countries, you can see that India has overtaken China in 2015 in terms of the number of cases of COPD, an estimated 55 million cases. COPD has now come down to the second position, and India and together are way above all the other countries in the world. So clearly, India and China alone contribute to more than 50% of the global burden of COPD, which I think is very, very important. If you look at the number of COPD deaths, you can appreciate the slope has been increasing in India since the year 2004. Is going up, up, up. China is still leading with 0.01 million cases higher than India. But I'm sure by 2020 now, by 2020, I would believe that India would have taken China in the number of deaths associated with COPD. When it comes to disability adjusted life years, which is a combination of death and suffering, there is absolutely no competition for India anywhere in the world. We are way above all the other countries in terms of disability adjusted life years. This is a very beautiful slide that talks about the disability adjusted life years across different states in India. So the further you're right, more disability adjusted life years adjusted for the population. And you can see that Uttar Pradesh is a state that has the highest burden of COPD among all the states in India, followed by West Bengal, Bihar, Uttarakhand, and so on. Goa is right on the top, which has the lowest amount of COPD amongst all other states and union territories in our country. But within these disability adjusted life years, there are 4 different color shades. The dark shade over here in blue is the one that is contributed by tobacco smoking, and the rest are all non-tobacco smoking risk factors. So some states, for example, like if you see Punjab over here, tobacco smoking is a very small contributor to COPD, whereas in other states like Mizoram, you can see that COPD is a major contributor, tobacco smoking is a major contributor to COPD. Just because we are in the middle of the COVID pandemic, I think I thought I'll just show one slide with COPD related to COVID. And we all know that the SARS-CoV-2 virus that causes the COVID-19 infection enters into the human tissue through the angiotensin converting enzyme receptor 2. These receptors are present in many tissues and cells in the body, especially in the oral cavity and in the tongue, but also in the upper respiratory tract and in the lung, alveolar epithelial cells. So the virus enters inside these alveolar epithelial cells and therefore gives rise to the formation of what we call as COVID pneumonias. Now, it is important to appreciate that if you're a smoker, your lungs would have higher amount of angiotensin converting enzyme 2 receptors, which means that if you're a smoker, the risk of you catching the COVID-19 infection is very high. If you're a non-COPD versus a COPD, COPDs are more likely to catch the COVID-19 infection than the non-COPD because of the greater expression of the ACE2 receptors in their lungs. So smoking increases ACE2 receptor expression in the lungs, and therefore smoking slash COPD increases the risk of COVID infection, which is I think, important for us to appreciate in our country. How widely is COPD recognized in our country? Was a research question that was addressed by one of my PhD students. And this is a study that we did in more than 3,000 randomly selected residents from the urban slums and 2,500 residents from the rural population of India. And we only asked them a simple question. Have you heard the word COPD? And the answer was yes in 0.7% of the population in the urban slums and 1% of the population in the rural areas. Thereby, meaning that more than 99% of the common in India, especially living in the urban areas, have not even heard the word COPD, especially when it's contributing to such a huge burden in our. How do you diagnose hypertension? Well, we have a very simple instrument called the BP apparatus. How do you diagnose ischemic heart disease? You have the electrocardiogram. How do you diagnose diabetes? You have the glucometer. Not many people are even aware about which is the diagnostic test for COPD. And that's where the problem even starts. Even in the healthcare community, spirometers are not easily available. Doctors are not well trained to perform spirometry. And on top of that, spirometry is indeed an effort-dependent test, which is not easy to perform. And therefore, there's a lot of underdiagnosis of COPD that occurs in India overall. This is an editorial that me and a colleague of mine, Dr. Anurag Agarwal from the Institute of Biology wrote in a journal, the JAPI journal a few years ago. India needs a national COPD prevention and control program. There's a huge burden. People are not aware about the disease. There's a lack of diagnosis and the lack of treatment that is contributing to a huge healthcare burden. So it is important to create awareness about COPD among all the stakeholders. It is important to prevent COPD by reducing the exposures to the risk factors, screen COPD in the community using simple tools, diagnose COPD and correctly using spirometry. For that, you need doctors, trained technicians. Then only that can happen. Treat COPD better, making the drugs available in the government health sector, making it available, affordable, and accessible for everybody, so that those who are diagnosed to have COPD get the right. And obviously, there is more need to develop research in this field of COPD, which is so very good for us. We cannot rely on the research on COPD conducted in the Western world to represent what is happening in our country. And therefore, it is important for us to generate our own COPD-related research to guide our policy decisions better. So I'm going to stop over here and I'm going to stop sharing. This was just to kickstart the session on COPD, and it gives me a great pleasure to invite the next speaker, Dr. P. A. Mahesh, who is the head at the JSS Hospital in Mysuru, a very good friend of mine, has contributed immensely in the field of COPD, has done a lot of original research in COPD in South India, and it will be a real pleasure to listen to him on the important topic of access to diagnosis and management required for COPD, what is working well and what is not working well. Dr. Mahesh, all yours.
Yeah, thank you, Sandeep, for the kind introduction and a wonderful lecture. As usual, I've been listening to you for the past 2 decades, and always your lectures are so nice, and your slides are superbly made. Sandeep, can you add my slides? Bhatia? Can you?
Sure, sir.
Yeah. Yeah, Sandeep has made my job easier.
Mahesh, you get the slides.
Yeah, sure, yes. So I'll be spending the next 10 minutes looking at the access to the diagnosis and the management required for COPD, what is working well and what is not. Can you make it a little larger?
Yeah, can you put it which is at the bottom right? Yes.
Yes. Now we will look at it. We will look at what is the some of the evidence from the literature, and then we will also look at maybe spend some time on what is my experience in treating these patients over the last quarter century. And I think can you go to the next slide, please? The biggest problem as far as COPD is concerned, as Sandeep just mentioned, is the name. People are not really aware of the name of COPD. Once the name itself is, people are not aware, then it becomes very difficult for us to educate them on the disease as well as its management. A lot of people think that COPD is, they use the same term, they use it for asthma. And they always say that their asthma is not under control. And we struggle with many of them to say that this is different. And for that, there is a name, though of course COPD is there in the Western world. There is no typical name in India. We still use the term COPD, which the public are not aware. Even the MBBS student and the respiratory care students are all taught COPD. But other than that particular group, nobody else in the general public, and as Sandeep has found out, a lot of people in the administration as well, in the government who are responsible for the health of the nation, also have some difficulties. And because of this, and because the disease is slowly progressive, and it starts about the age of 50 years in most people, who tend to relate these difficulties, they say, I am now older, I cannot manage as well as I did earlier. Therefore, they don't seek medical attention. And that's the biggest problem for us. Because when you do a spirometry, I am happy if I see a lung function FEV1 of 30%. Usually I get 20%, 15%. By the time they come to me, if I see 30%, I am extremely happy. So that's one of the biggest problems. They relate it to their aging process. And therefore, they are not able to manage as well as they did earlier. Rather than seeking medical care and thinking that it is related to the disease. Added to that, we also have difficulties in access to high quality medical care. In the sense that it's a very basic, if you are looking at very basic COPD management, first you need to make a diagnosis. You can't do that without a spirometry. Now the problem is most of the practitioners, health care providers in the country don't use spirometry. except the pulmonologists and a small proportion of physicians with special interest in respiratory diseases. Everybody has, they may even have an echo. Even an MD physician will have an echo in their sort of consultation room, but they will not have a spirometer. If you go to the labs, they do a lot of this test. They will have a very high-end CT, MRI, 3 Tesla MRI and everything, but they will not have a spirometer. And even in places where they have, whatever, see, I've seen from Mysore, Bangalore, when they come, the spirometric quality is very poor and nobody can interpret it. It's just done for namesake. Because it needs, as Sandeep said, it is effort dependent and therefore very difficult to do. And we also find that people have difficulties following the medical advice, especially when you say smoking cessation. Even when the lung function is 15%, they still have difficulties in quitting smoking. For, of course, women who are still cooking and exposed to biomass or somebody else, it is very difficult. Of course, now with the Ujjwala scheme, it is different. But earlier, it was very difficult for us because there is no way they can use an alternate fuel. Next slide, please. The key problem is the MBBS training happens for clinical medicine from the internal medicine. They do have 15 days of pulmonology posting, but they don't actually do any spirometry themselves. They don't spend time in the OPD. The BSc respiratory care are really taught on how to do, but the MBBS people are not. They do not know. And the problem is they are in medicine. They spend a lot of their time in clinical medicine under internal medicine. And none of them ever do spirometry. Even in medical colleges, forget about other places. And therefore, they pass out having never seen a spirometer, having never seen what a spirogram looks like. And therefore, they are never comfortable. After that, people also the way the update is less. And they are also drawn, once you are an MD physician, they are drawn more towards cardiac diseases. And therefore, the emphasis on the respiratory, which is mainly a poor man's disease, is quite less. Even when they say tobacco is a risk factor and ask for all the cardiovascular tests, they will never ask for a spirometry to assess the lungs. Very, very small number of physicians will even think of referring a case to a pulmonologist. We did a study looking at the number of people with COPD who also have cardiac problems. So we talked to the cardiologist, gave a thesis, and found that more than 1/3 of the patients had COPD who were not treated. They all attributed their dyspnea to their cardiovascular disease and not to the respiratory disease. And the cardiologist, until we went and put our MD student there to actually do this study, never asked for a spirometry in our own medical college. And then they realized that more than 1/3 of the people had COPD. And managing their COPD caused a tremendous improvement in their quality of life and dyspnea. So that is the state in medical colleges. You can imagine the state in the non-medical college setup, which is supposed to be more academic. This is the state of affairs. I think not being able to give a locally acceptable name, that is, I think, an urgent need. Maybe I request Sandeep to take that and come up with and that's the first thing I think we need to do to actually spread the awareness about the disease. The number of pulmonologists are low in most places, and there is an unequitable distribution of the doctors in urban compared to rural areas. Probably Kerala is the most literate state that we have in India and the most healthcare conscious. I did my PG in Kerala, spent 3 years there. I found the people extremely healthcare conscious. They will read up and ask whether you need to do this investigation or not. And the study, if you see from Sanjay Nair and Arjun, 90% of COPD patients, it was done in 2 places, were not given a diagnosis of COPD. That is the state in the best, highly literate, probably the best in healthcare, and they have their under 5 mortality and so many other health indicators almost on par with the Western world. And that's the state of affairs in a state like Kerala. You can imagine the rest of the country. Next slide. Now, quality control in spirometry is very tough. You not only have to look at the whole spirogram, there are so many parameters, there is no time to go into that. But the gold standard for that is the BOLD study done initially in more than 60 countries. In the second phase, again Mysore and Pune are all part of the BOLD 2. And they have developed a software. Again, possibly there is a need, maybe it will help revolutionize COPD care. So possibly this is something we should look for. And that looks at different parameters like your quality control. You are given a score for pre and post bronchodilator for the FEV1, FEC, and post expiratory time. Next slide. Back extrapolated volume and end of test volume. Next and next. So the different quality control measures other than what you routinely see. Because if you go to a software guy, again we try to do that. It is tough. If you go to a software guy, the BOLD took a computer engineer and a statistician. They spent 1 year to develop this software. Now, when we sat with the software engineer, he said, what we see FEV1, that is in 1 second, has more than 150 points that you can use for quality control. So if you can bring in what we see visually as just 1 second, that has 150 points there that you can use for better quality control. The softwares can do that. And I think that should be the way forward if India has to really move ahead with COPD management. Next slide. Again, what is not working well for the doctors is in the last 15 years, you have only 12 articles on COPD. This is an ICMR journal, IJMR. It's only 12 articles that will tell you the amount of research that is happening, which is published in the premier journal. And most of the physicians read the JAPI, and there are about 14 articles on COPD in the last 15 years, and that includes the editorial that Sandeep Salvi just showed. So you can imagine. Next slide. Not working well from the public health government. If you look at the national program on cancer, diabetes, and cardiovascular disease and stroke, and look at the risk, where COPD is mentioned twice, diabetes is mentioned 87 times. Very little COPD research in India, which is the second most important cause of death, because it's not funded. Research will happen if it is funded. If it is not funded, it's unlikely to happen. Never a large national program until now, until recently, such a large funding to have a nationwide or in different parts of the country has not happened. Sandeep just talked about, and in 2012 he has already proposed, and I know he's been pressing for long, and I hope he will succeed soon, to have a national program on COPD similar to tuberculosis or malaria, though it affects and kills and more people. Most PHCs do not have healthcare personnel equipped to diagnose and manage COPD. Most PHCs may not be able to regularly supply the needed inhaled medications in their area of coverage. Next slide. Now let's go to what is working well. Compared to say 25 years ago, the acceptance of inhalers now we find much better. Earlier I had to spend half an hour to the patient to explain. Now I say I'm going to prescribe you inhalers. I look at the patient and there is no question. They are ready to take the inhaler and you don't need to really spend the time. They have understood that's the best way to go. Some improvement in understanding difference between asthma and COPD in the urban population is there compared to earlier. Next slide, please. What's also working well is the number of MD seats in pulmonary medicine, and DNB is more, though it is still skewed in urban areas. At least in the urban areas, people who come to contact with the pulmonologist, they tend to seek organ specialists now, and they will, if they have symptoms, they will come, and they tend to know that COPD and asthma are different. Still a long way to go, but it's happening. Corporate hospitals now, most of whom will have one pulmonologist, at least, will have added now spirometry to their battery of tests. Unfortunately, most of them I have seen still do only pre-bronchodilator and not post-bronchodilator, which is the most essential to diagnose you. Next slide. What's working well with the public health and the government? The regulatory control that has kept the prices affordable for most patients, I think, is the most brilliant move so far that has happened in as far as regulatory effects are concerned. We talked to our friends in Sri Lanka and Bangladesh, and they are struggling to cope. Only the Indian medicines are affordable to most of their patients, but not the ones that come from Europe or US. Banning smoking in public places, quite important. Changing the labeling on cigarette packs, important. PM's Ujjwala scheme, again, for biomass COPD, that is the biggest help. I understand in the North India where you have a joint family and you have to make 200 rotis every day, people are still using the old chulas and tandoors are not really shifted to LPG. But in South India where they use a ragi or rice, the LPG is more acceptable. We screened about nearly 8,457 people, and which had about 4,000 women. In 2006, 16 villages randomly selected for our Mudra cohort. Biomass use in 2006 was 100%. 2019-20, we are working with Karolinska Institute to study biomass COPD in more detail, studying about 40 cytokines, and we find that 1/3 use LPG on daily basis, 1/3 use biomass, and 1/3 use mixed of the biomass and LPG. In the last few years, Kerala has started a SWAS program for COPD and asthma, and that's a welcome initiative which I hope will be taken up by other states and the center as well. MCI inspections have made mandatory for all medical colleges to have a spirometry, and that is something good. And DBT currently, in July, we realized that they are focusing on COPD research at a national level. That's an extremely welcome initiative. Next slide, please. Now, what could help? Sandeep has already listed quite a few of them. Next slide, please. We need help of the media, regional media, cable TV, to really bring out, and print media, to really bring out both in national and the local languages, educate people on COPD and say this is different from your regular run-of-the-mill asthma. Low-cost spirometry or a low-cost diagnostic tool. Again, I know Sandeep is working on it. In the last talk, he shared his results, and I hope he will be able to publish it shortly. And that can be used in any PHCs in the country and in other low-income countries as well. The National COPD program that provides a proper diagnosis, access to medicines, pulmonary rehab, availability of appropriate inhaled medicines continuously at PHC, similar to the TB program. TB program is running extremely well. HIV programs are running extremely well. The government is doing extremely well. If COPD is added in the same basket and run the same way, it will make a big difference. Training for physicians, again, Sandeep, along with the PHFI led, and the Narayan Hridayalaya, Dr. Burli Mohan, led this certificate course and training of the general practitioners and physicians. It did very well. 25 centers and almost 600 people were trained, and certain state governments also adopted this. Next slide, please. So this certificate course made a big difference. Next slide, please. With the PM, as I said, the PM Ujjwala's scheme has helped 70 million households to date, and possibly it can reach further. And somehow we need to look at maybe a solar cook stove may be more relevant in North India when they have to say cook for 50, 60 people in the house. Improving ventilation, even having the door open and a few windows will make a big difference when cooking is done inside the house using biomass fuels. Screening for at-risk groups, people who are with occupational exposure, smokers. It is useful to have a screening, add it to the master health checkup, but do a post-bronchodilator. That will make a big difference. Exercise and pulmonary rehab. Even in medical colleges, these are expensive. Once we refer, they go there for say 6 to 8 weeks. They say it is very expensive. So we need to come up with some program which can be done by the patient in the house without any expense. Then they are likely to do. When they struggle to buy medicines, it's unlikely they will go to a pulmonary rehab, at least in a place like Mysore and the kind of patients that I see. Next slide, please. Next slide, please. Yeah, thank you very much. That's the Jesus Hospital where I work. It's quite close to the Mysore Palace. Thank you very much.
Thank you, Mahesh, for an absolutely brilliant, thoughtful, and a very insightful talk on where are we going wrong and where are we making some changes. Absolutely brilliant, Mahesh. Thank you so much. I think I'll make a small summary of this at the end of all speakers. So it's a great pleasure to invite the next speaker, Dr. Rajesh V, who is the head of the Department of Respiratory Medicine at the Rajagiri Hospital in Kochi, a very eminent and renowned pulmonologist in Kerala. And he's going to talk on access to diagnosis and management required for COPD. What is important for the future? So, Dr. Rajesh, all yours.
Thank you, Sandeep, sir. And at the outset, I will congratulate IAHD India and IARC for coming up with this very innovative session. And my personal words of gratitude to Dr. Sandeep Bhatia, Dr. Ruji, and Ms. Madhura. So it's indeed a pleasure to be in the same boat as Sandeep sir and Dr. Mahesh. And the next 10 minutes or so, I will share with you some of the unmet needs in COPD patient, both from the patient point of view as well as the clinician point of view, the diagnostic pitfalls, including the late diagnosis and reliance on imperfect diagnostic tools, some of the management pitfalls where we generally concentrate on treatment rather than prevention, the lack of a holistic care when it comes to COPD management, and probably the lack of high efficacy drugs when it comes to the treatment of COPD. And I do realize that most of these aspects have been already stressed by Sandeep sir and Dr. Mahesh, but I think I will just serve as a refresher for whatever they have said. So we'll start off with a couple of disclaimers that I'm a hardcore clinician, I'm not a researcher, I'm not an academician or a policy maker. So if I am more inclined to stressing on the clinical aspects, please bear with me. And again, I am focusing on real life challenges with less of published evidences. So the first and foremost thing that we need to do better in the future is that we need to acknowledge that COPD is a major health problem in our country. Again, stressed a lot by Sandeep sir and Dr. Mahesh. We have to realize and accept that COPD is a major health problem. We have to start focusing on our policies against COPD. We have to allocate much more funds on the care of COPD, research on COPD, and grassroots level of implementation of many of the programs. That is a foremost unmet need and challenge. And unless we don't do it, we are not going to reach anywhere when we go to the delivery of care in COPD. And again, something that has been really stressed in the previous talks, that as opposed to many of other chronic diseases, which are actually sort of tapering or plateauing due to better awareness and better preventive facilities. COPD is one of those diseases which still has a very steep ascending curve when it comes to a number of cases, morbidity, and mortality.
Sorry to interrupt, Dr. Rajesh. You need to share your slides, please.
Oh my God.
Okay, Rajesh, Dr. Rajesh, I'm sure you can speak extempore on the points that you.
Shall we share from our side, Dr. Rajesh?
I have already shared, I thought.
So let us share. Ruchi, can you share? Yes.
Is it visible?
Yes. Yes.
I'm actually on my 7th slide actually.
Okay.
Or should I start from 1?
No. Please carry on from.
Yes, carry on.
Okay. Now I'm in my 7th slide. Okay. So what I was trying to share is that in contrast to many other chronic diseases, COPD is one of those diseases where the incidence is still on the upward surge, as opposed to many other chronic diseases where better awareness and better preventive programs have actually led to some degree of plateauing of the incidence of diseases. Now, the second most important thing that we need to do correct in the future is utilize early and very accurate diagnostic tools when it comes to the diagnosis of COPD. As Dr. Sandeep Salvi very clearly pointed out, the test of prime importance or the gold standard test in the clinical level when it comes to diagnosis of COPD is a spirometry. Now, we'll just dwell upon a second on this particular landmark study in the late 1960s or 70s, where the FEV1 decline in those with COPD, whereas those with non-smokers was compared. It was very clearly seen that the lung function, as evidenced by the FEV1 values, had a very steep fall in those susceptible smokers as compared to non-smokers. And at any stage, if the patient actually quits smoking, then the improvement or rather the fall of FEV1 tends to be less steep. So similarly,
Dr. Raj, are you changing the slides or is somebody else changing the slide?
I am changing.
Okay, because the slide did not change.
Oh. Now, which is the slide that's visible? It's a red slide.
Global trends in this thing.
Oh my God.
Oh, now even smokers is being seen.
Just a minute. It's not sharing actually properly. Now we need to share on. Okay, now I am sharing my slides.
Yes, Dr. Rajesh, we can see the FEV1 in smokers. Now, if you could make that full screen. Yeah, if you could only make it full screen. Correct.
Yeah.
Yes, now we can.
Okay.
Yeah.
Okay. Now we move to the next slide. Okay, yeah. If you see the natural course of COPD, then you have an initial phase where there are risk factors, but there is no fall in lung function. And then you have a stage where there is slow but steady fall of lung function where the tests are abnormal, but the patient doesn't have any symptoms. And then there is a stage where the patient significantly has progressive symptoms and progressive loss of lung function. And then finally, you have an accelerated course characterized by frequent exacerbations of COPD. Now, the thing that we should do in the future in the first stage is that in this stage, the patients have normal lung function. The most important thing is risk factor reduction. Okay, now that can be achieved by smoking cessation or lack of exposure to biomass fuels and all those things. The next stage will be you have abnormal tests but no symptoms. So here is the importance of diagnostic testing by way of spirometry. And the third and fourth stage, in addition to doing all these things, risk factor reduction, early diagnosis by spirometry and all, you need a holistic care, really focusing on drug therapy as well as pulmonary rehabilitation. So when you come to early diagnosis, look for risk factors, look for symptoms, but test, and test. Do a baseline screening by spirometry and then serial testing in periodic intervals depending upon how the patient fares with respect to symptoms and all. And spirometry is the practical life gold standard for diagnosis of COPD. And we need a COPD conscious clinician also to make an early diagnosis. Again, access to and utilization of quality spirometry is a real problem in our country. Yes, I have told many times that perhaps spirometry is the best test to conclusively diagnose COPD, but it's a crucially technique dependent and effort dependent test. So the focus for tomorrow will be to ensure wide availability of spirometry at secondary care levels or even lower, even primary care levels when it comes to government care. Insist on diagnosis of COPD using spirometry, emphasis on a standardized technique and good infection control in the PFT lab. So quality control in spirometry, the ATS documents provide excellent steps in performance and interpretation. Utmost importance is to be given for infection control. And one word regarding the training of personnel. We propose to have a 1-year pulmonary technician training program where they need to perform at least a very standard number of spirometries under supervision in a standardized institution with good technical support and clinician support. And the spirometry should be mandatorily performed by a certified technician because we have certification programs for multiple things. We don't have a certification program for a spirometry technician. So that is something which probably needs to be mandatorily incorporated in our healthcare system. The fourth step that we need is to need for setting up COPD care teams, because this is an era where a single person, however brilliant he is, cannot achieve something extraordinary. For achieving something extraordinary, we need teams. So we need an internist or a general practitioner or a pulmonologist. Anyone who is really focused in COPD can deliver good care. I would still feel that we should stress on pulmonologists because here you have a training program which is highly focused on pulmonology, on COPD. So I would say that whenever possible, let a pulmonologist manage a COPD. If not possible, at least an internist or a general practitioner having good focus and aptitude towards treating COPD. And have specialist pulmonologist posts in secondary care levels mandatorily. When I say that, in a taluk headquarters hospital or a district hospital, we need to have a specialist pulmonology post who works solely on pulmonology. He should not be rotated to other systems of, say internal medicine duties or something like that. In tertiary care facilities and corporate hospitals, have at least 2 pulmonologists in each institution. Have a focused paramedical force in the COPD care team where 1 certified pulmonary technician, 1 respiratory therapist, plus or minus a physiotherapist who is focused in pulmonary rehabilitation, and have pulmonology representation in decision making and policy making forums. That is very important because only the practicing pulmonologists can understand what are the real life challenges when it comes to COPD management. And last but not the least, focus on medications and interventions, because we know that what the current medicines achieve is that they do some degree of symptomatic relief to dyspnea. They have very limited impact on cough or phlegm production. Only partial relief is provided. They retard worsening of lung functions, but they cannot reverse or normalize lung functions. They do decrease exacerbations, but the impact on longevity is more or less limited. So probably we need to focus on research to find out drugs that can preserve or reverse the decline in lung function, do better symptomatic relief, especially when it comes to cough, phlegm production, and dyspnea. We need to find out drugs which can actually improve longevity. We need to have drugs which improve exercise tolerance and make a sort of vocational rehabilitation for the patient, and better drugs that prevent exacerbations when it comes to the accelerated phase of COPD. So again, pulmonary rehabilitation, we need to realize the need and benefits of pulmonary rehabilitation, the ability to implement good quality rehabilitation program and set up centers of excellence for that. So if I can just summarize what I told in the last 10 minutes, we need a national emphasis on COPD, realize that it is a major health problem, start allocating resources and personnel to COPD care. Focus on early diagnosis by screening, questionnaires, and emphasis on spirometry mandatorily for diagnosis of COPD. Impart quality training programs on spirometry and have a mandatorily certification program, and any good quality spirometry should be performed by a certified personnel. COPD care team establishment with central role for pulmonologists and a good COPD focused team, research on new drugs and focus on pulmonary rehabilitation. Thank you.
That was absolutely brilliant, Dr. Rajesh. Very, very well put. I think you highlighted all the important aspects and the challenges that a physician faces in practice. And so I think I really like the solutions part of your presentation. Very well put. Thank you, Dr. Rajesh. The next presentation is going to be done by Dr. Pradeep Joshi, who is a National Program Officer for the World Health Organization for India. And it will be really interesting to see his viewpoint on the WHO perspectives and recommendations to India for prevention and management of COPD. Dr. Pradeep Joshi, please.
Good evening, Dr. Salvi sir, and thank you again IIHD and IARC for giving this opportunity. And I also convey my regards to the other panelists as well as to the participants. So good evening to all of you. May I request Dr. Sandeep to share those slides, and then I can start the presentation. So the topic allocated to me, as Dr. Salvi has mentioned, is about the prevention and control of COPD and giving the perspective of the WHO and the recommendation. So I have broadly covered a few issues, and here I will just mention few of the things which already have been cited by the earlier speakers. So no doubt COPD is a major preventable chronic respiratory disease, and globally there are around 65 million people who suffer from the COPD, and annual mortality is around 3 million. And the highest burden is in the low and middle income countries, which includes India. And in India, as Salvi sir was the was leading the COPD group, and this has found that around 75% of the total Delhi was due to the 75% of the total Delhi's were COPD contributes. So, and the prevalence has increased almost 30% in the last 2 decades. It has been now around 4.2%. So regarding the risk factors, and it has been clearly mentioned that tobacco use, especially the smoking, was earlier as a major risk factor, but now with the increasing prevalence of the air pollution and the occupational health hazards, these are the leading cause of the COPD. So just few lines about the risk factors. And recently the GATT survey has mentioned there are 267 million tobacco users in India, and the particulate matter 2.5 is around 62 microgram per. So it is more than the national standards. And the economic burden of COPD was estimated, was projected around 480 billion for the year of 2016. So coming to my next slide, about the prevention of the COPD. If we talk about the prevention, there are mainly the 3 dimensions where we can think of the prevention of the COPD. One is about prevention of the lung health and the primary health prevention of the lung health and the primary prevention. And here mainly it is undertaking the policies and program measures to decrease the risk factors, mainly due to the non-communicable disease, which is tobacco smoking, exposure to the secondhand smoke, indoor and outdoor air pollution, occupational exposure to dust and hazardous fumes. And also we require the community-based integrated interventions, which creates more healthy environment. It's not only one policy measures, it's a combination of the policy measures which are required at the community level. and especially for the poor and disadvantaged population, as previously speaker has mentioned that it is more in the poor people. And same in the primary prevention is about the increased public awareness of the risk factors. And I want to emphasize here that especially raising the awareness among the person who are at the high risk. And we have seen there are gaps. So the public awareness should be utilized based on the evidence-based approach, and should be regularly reviewed for increasing its effectiveness and the outreach. The other important pillar for the prevention of the COPD is estimating the burden and identifying those risk factors and undertaking the surveillance. As clearly mentioned earlier, that there are very few research in the COPD area, and we have to think over it. And the other part of the primary prevention is identifying them early and the risk stratification of those who have been at high risk. So the heterogeneity of the COPD itself it's a challenge for prevention of the COPD. So in the next few slides, I am highlighting on the few of the risk factors and giving a view on the participants how those risk factors can contribute to the COPD and what are the preventive measures available for the for reducing those risk factors. If you see this slide, this is based on the risk factor global burden of disease, and if you see the contribution of the tobacco in the major disease, if besides lung cancer, which is the most important cause of death due to the tobacco, the second most is COPD, and it is almost equal. The other risk factors and the tobacco use, in the 2016, it was clearly mentioned that the tobacco use is almost around 50% of the deaths due to the tobacco use is there. And tobacco use approximately causes around 8 million deaths per year. And next slide, please. So WHO has come up with the Framework Convention on Tobacco Control, which we call as WHO FCTC, and it was adopted in 2003 and came into force in 2005. It was developed in response to the globalization of tobacco epidemic, and there are good bias which are mentioned in the WHO FCTC, but if we want to further filter it out, the best practices, it is Empower. So and it is an acronyms, and it has been mentioned in the slide. There are different articles of the WHO FCTC. So Article 20, which is monitoring the tobacco use and prevention policy, and Article 8, which describes about protecting people from tobacco smoke, and Article 14, which provides which mentions about cessation services, Article 11 and 12, which warn about the dangers of the tobacco, and Article 13 mention about enforcing the ban of tobacco, comprehensive banning of the advertisement and promotion and sponsorship of tobacco products. And the most important is Article 6, which talks about the raising the taxes on the tobacco. These are the best buys for controlling any tobacco measures. These are empowers are essential. If we go to the next slide, we just can see the impact of Empower. And in the 2007, when the only 1,000 million population was protected from tobacco, it was rose to in 2018 to around 500,000 million population, and the countries also have been increased which are implementing at least one power policy. AM is monitor, so others are the measurable features. So in the power policy at the highest level of achievement. So I just want to mention here that India has been given 1 point on the highest achievement in 2014, when the large pack warning was more than 70% of the display was notified by the government of India. So this is related to prevention of the tobacco. And next slide, please. Now we come to the which is now becoming a leading cause of the COPD. And if you see about the dailies in the due to the tobacco, due to the ambient air pollution, it is basically the dailies are highest in the Haryana and Uttar Pradesh, followed by this Punjab, Rajasthan, Bihar, and West Bengal. And in the closer, in the subsequent graph, you can see that how many standardized mortality is caused by the air pollution. So the Southeast Asia regional average is around 165, and the global average is 141. The mortality rate per 100,000 population, and India is well ahead both in the regional average as well as in the global average. And based on the analysis, it has been found that air pollution related deaths attributable to selected NCDs, it is around 25%. COPD contributes to 25% of air pollution related deaths. Next slide, please. So for reducing the air pollution, there are options available, and it is some of the options are given in the air pollution in Asia and Pacific science-based solution. And these are not the new solution; they are already well known. But it give you which are implementable at the all country level, which are implemented at the lower middle income countries. So some of the best intervention, there are 25 measures which have been identified, and these are like post consumption controls, industrial process emission standards, setting up emission standards for the road vehicles, vehicle inspection. So these are related, some are related to the transport, some are related to the industries and minings, and implementation of those measures is required to control the ambient air pollution mainly. Next slide, please. So if we go to the next campaign, which was started by WHO in partnership with the Clean and Climate and Clean Air Coalition and UN Environment, was known as a Breathe Life. And Breathe Life is basically which provides a platform for the cities to share their best practices. It works with the municipalities to expand monitor efforts to keep their citizens informed, and build demand for the new solutions, and actually raising awareness and educating people about the air pollution harms. And in this Breathe Life campaign, 4 cities of India have been participating. One is Nagpur, Bangalore, the second is Bangalore, Bhubaneswar, and Dehradun. These are the 4 cities which are participating in the Breathe Life campaign. Next slide, please. Another important contributor which has been raised by the expert is this indoor air pollution. So in that, this is WHO has come up with the Clean Household Energy Solution Toolkit, and there are which is acronym as given as a CHEST, and there are different modules, and there are step-by-step process which you have to do to assess what is required at the country level or at the local level to reduce this indoor air pollution. So basically it is about the situation analysis or the stakeholder mapping. Second, identification of the interventions or technologies. Then the guidance on the standards and testing, monitoring and evaluation, engaging the community, and raising awareness. So on the CHEST also, there is an India report which has been recently published, which gives a comprehensive analysis of what is happening related to the indoor air pollution in India, what are the challenges and what best can be done. So there are some recommendations which has been published after doing the analysis based on this toolkit. Next slide, please. So there is a good progress, and there are policy implementations have been reason for this. If you see in the 2000, in last 15 years, there is a decline of more than 52% in the solid fuel use. And if you see the Southeast Asia region comparison, India is still having a high use of this solid fuels. So definitely there is an opportunity where action is required. Next, please. About the management of the COPDs, it has been clearly mentioned it is largely underdiagnosed and undertreated, and there are health system challenges which need to be addressed. And I think Dr. Bachani will be speaking more about at the primary healthcare level what can be done. But the challenges related to early diagnosis, availability and accessibility of the diagnostic and drugs, the HR challenges, the counseling challenges, there are multiple challenges. So there is a tool which has been developed by the WHO, which is called as WHO PAN tool, a package of essential non-communicable disease interventions at the primary health care. And in that series, All India Institute of Medical Science also have developed with the WHO management of the chronic respiratory disease. And you can just see that there are simple process which has been provided and step-by-step approach which can be done at the primary healthcare level for the management of the chronic obstructive diseases. The new intervention using the mobile health, there in the Be Healthy, Be Mobile initiatives, there is an tool developed which is called as for asthma and the chronic COPD, which we call as AM Breathe Freely. And here there are contextualized SMS being sent to the high-risk patients on a regular basis about the COPD and how it can be prevented. Next slide, please. So WHO has come up with this best by interventions for tackling NCDs, and these are based on the effective interventions of cost-effective analysis about spending $1 and averting about 100 per Delhi. And based on that, they are classified into three categories. One is best by, which is given 3 circles. The second is the effective interventions, 2 circles, and other recommendations where the cost effective interventions is not available. I don't know whether you are able to see or not, but the COPD for management of chronic respiratory disease, the management of the COPD by inhaled salbutamol and treatment for asthma has been given as a effective interventions, and the cost effective analysis per dollar spent is still not available for how much we can gain from improving the stoves and providing cleaner fuels and other interventions to reduce the COPD and the chronic respiratory disease. But the work is in progress. So definitely the the COPD has been mentioned as one of the effective intervention in the WHO best by. Now, next slide, please. So if we come to the available policy options and strategies, I just want to mention there is a national health policy which clearly mentions about reducing the risk factors, especially the tobacco, and also addressing the non-communicable disease, which includes the chronic respiratory disease, which include both asthma and the COPD. Also, there is a national multi-sector action plan for prevention and control of non-communicable disease has been developed, which is a multi-sectoral response where more than 29 ministries have been agreed for doing those interventions which can prevent the 4 common non-communicable diseases and their risk factors, including the chronic respiratory diseases. There are 10 targets which have been established in the National NCD Monitoring Framework, which also has linkages with the reduction or the prevention of the COPD. One is about the overall mortality reduction from the 25% mortality reduction. The another one is reduction about the indoor air pollution by 50% and increasing the accessibility of essential drugs and diagnostics, reduction in the 30% reduction in the tobacco use. So these are the targets which has been set up, and these are the policy options which are available. More, next slide please. More need to be done, and we have to leverage on the different policy options which are already available, and few of them which I have mentioned and can address those risk factors. One is this new national policy on the biofuels, which mentions about increasing the utilization of biofuels in the energy and transportation sector. Ujjwala scheme already have been highlighted. There are more than 80 million beneficiaries, and it has contributed in the reduction of the uh, indoor air pollution. We have this national clean air program to reduce the level of air pollution and have a target of reduction of 20 to 30% of PM 2.5 and PM 10 concentration by 2024. Another intervention is about this International Solar Alliance, which has been spearheaded by India, and the goal is the global deployment of around 1,000 gigawatt of solar energy and mobilization of investment in tune of more than 100 billion in solar energy by 2020. Other interventions are this COTPA. You are well aware about the COTPA, which prohibits the advertisement and regulation and trade of the cigarette and other tobacco products. And in that series, this electronic nicotine delivery system has also been notified as has been banned completely in India. The other two interventions, the other two policy options which are which can be leveraged for management of the COPDs is, one is this Pradhan Mantri Jan Arogya Yojana under Ayushman Bharat, and the second one is the Health and Wellness Center, which Government of India is doing, and there are both from early identification, the screening, early identification, and follow up, and a referral of the NCD patients, including the chronic respiratory disease patients. So this was all from my side, and thank you so much again for this opportunity. Thank you.
Thank you very much, Dr. Pradeep Joshi, for a very elaborate, there's a lot of views that you have expressed on the role of WHO in managing COPD in India. In the interest of time, let me go straight away to the next speaker, which is a very, very important talk and a very important speaker, Dr. Damodar Bachani, who is the former Deputy Director General, Minister of Health and Family Welfare. He has been instrumental in developing a lot of important healthcare policies. I was very fortunate enough to be a part of the steering committee that he led on air pollution and health. So he has all the knowledge that is happening inside the Minister of Health and Family Welfare with regard to policy decision makers. And he's going to tell us about how can we leverage primary healthcare system to effectively manage COPD. Dr. Bachani, please, all yours. Look forward to your talk.
Thank you, Dr. Sandeep. I hope somebody will share the slides. So much has already been said about COPD, its diagnosis, treatment. So being a last speaker, it makes things quite easy for me. Next slide, please. It's providing primary health care. It's in the government sector is primary health care centers, community health centers, and also not forgetting health and wellness centers that have now been set up. Actually, these are mainly sub-centers and PSCs that have been now renamed as health and wellness center. But also a large number of GPs are also providing primary health care. We shouldn't forget that. So why it is important, and rather I would say easy to build on the existing primary healthcare system, both in the government and the private sector, to leverage and lead on prevention, diagnosis, and treatment of COPD. It's actually needed much in rural areas as well as urban poor communities where most of the undiagnosed cases lie. Actually, in the year 2015-16, when I was in the ministry as Deputy Commissioner NCD, we did get included COPD under the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease, and Stroke. Actually, COPD and chronic kidney disease were included. But if you look at the screening program that has been done now, population-based screening, it's mainly concentrating on diabetes through glucometers, hypertension, and some common cancers like breast cancer and cervical cancer and oral cancer, but not COPD. That's the issue, how we can include. And as has been said by previous speakers, spirometry is perhaps the best way to introduce COPD. That's the gold standard. Another important thing is, bath programs. People who are having chronic cough, mainly they go for exclusion of tuberculosis under revised National Tuberculosis Control Program. And what happens if they are negative? They are not referred anywhere. They said, "Tumhe TB nahi hai," that's it. They may be having COPD. So what I want to say is that there is no cross-referral system between DOT centers or TB centers and NCT clinics, which should also include COPD in their gambit. So if there's a cross-referral system between the two systems, and if TB is negative, there should be a referral system to COPD. And these NCT clinics should be equipped. Of course, spirometry would be one of the inputs that would be required, but also for treatment, many medicines and gadgets. So we should also ensure that whatever drugs are required for management of COPD are made available. There's a very good inventory system now available under the National Health Mission, and essential drugs required for managing COPD should be made available under this system. Next please. Now, some of the following slides are actually based on what Pradeep also mentioned, a WHO-assisted activity that developed guidelines for management of COPD under the leadership of Dr. Guleria, who is now the director of AIMS, and I was a member of this thing. So we have to train the physicians, both GPs and doctors who are posted at the primary level, about what are the signs that are suggestive of COPD: progressive dyspnea, chronic cough, chronic sputum production, and also try to assess whether they are exposed to any of these three important risk factors. Much has been talked about tobacco smoking and also biomass, particularly in the rural areas and urban slums. They are being used even now, in spite of Ujjwala. And occupational exposure. Don't forget those who are engaged in dusty trades, like some factories. If there are any signs of chest pain or fever, except when there is, super-dead infection in COPD also, there should not be any fever. Significant weight loss, orthopnea, paroxysmal nocturnal dyspnea, or hemoptysis, rule out whether there is any other disease that this person may have besides chronic cough. Next, please. And next slide. So if there's chest pain, you should rule out cardiac diseases. Go to the back one. If there is fever associated, it could be pneumonia, tuberculosis, or bronchiectasis. If there's weight loss, it could be because of TB or lung cancer. If there's orthopnea or paroxysmal nocturnal dyspnea or pedal edema, swelling on feet, you should rule out congestive heart failure. If there is blood in the sputum, hemoptysis, rule out TB, lung cancer, and bronchiectasis. And if there's family history, it could be asthma as well. Next. So spirometry suggested is the main key. Next, please. And it is now available in both forms, PFT lab spirometers as well as handheld spirometers. So under the NPCTCS program, and I was there, we did mention that we should include handheld spirometers at CSCs and PSCs so that diagnosis of COPD could be done. Without which, just symptomatic treatment is being given, which is continued to be given, and that may not be enough. Next, please. And these are some of the measures I think previous speakers have already mentioned about forced vital capacity, forced expiratory volume in 1 second, and the ratio. These are all important parameters, not only to diagnose COPD, but also to rule out whether it's restrictive or obstructive COPD. Next. Next, please. This has been spoken. So this is a simple diagram that has to be put under in every PSC, every GP, that if a patient at the primary level is reporting his age is more than 35, there is exposure to any of the risk factors of COPD as mentioned, including tobacco, and there are symptoms that are suggestive of COPD, go for physical signs of COPD, and then go for acid-fast bacilli, that is to rule out tuberculosis in the sputum. If it is positive, they go to the DOT center. If it is negative, then they go to the NCT clinic. And that's the link which is missing. I put it in red. That has to be activated virtually, cross-referral between DOTs and NCT clinics. Next, please. There may be situations when there is exaggeration of symptoms or any of these signs like cyanosis, like blood pressure has gone down below 90, systolic blood pressure. Respiratory rate has increased or heart rate has increased or pulse oximeter shows oxygen level less than 90, then these are serious cases. Deaths occur in such cases, and you have to have not only trained physicians to give initial treatment to such cases, but immediately send for referral to higher levels. The next slide will show that, so that they could be taken care of. So there has to be linkage between primary, secondary, and tertiary. It's not just giving relief to the patient, but also avoidable deaths and try to prolong their life as far as possible and improve their quality of life. I'll stop here. Thank you very much.
Thank you, Dr. Bachani. I think that was a very, very thoughtful presentation. So in the interest of time, what I'm going to do is just give a very quick, concluding remarks, just basic carry-home messages that all the members actually gave to us, so that we can summarize all this. It is very important to do that at the end. So Dr. Mahesh, his presentation was primarily focused on few carry-home messages that I got. The name is the biggest problem, COPD. Do we need to have a separate name for India? And he has recommended that we should address this issue. He talked about the quality of parameters being done in India, the importance of medical education, where COPD and parametry are very poorly taught, and that's where the basic root of the problem could potentially lie. So that's where we need to bring about a change. The NCI regulation and change in the curriculum. We also recommended that there should be more research. We need to have more publications on COPD in India, and treatment has to be affordable. In fact, we are very fortunate enough to live in a country where treatment is indeed very affordable, and we should make maximum use of that. So those are the important carry-home messages that I got from Dr. Mahesh. Dr. Rajesh also gave a very beautiful presentation on practical challenges that a physician encounters. He emphasized on the importance of acknowledging that COPD is a big public health problem. We need to wake up and start doing something about it. He also talked about the importance of spirometry. And one of the important messages that he gave was the need to have a mandatory certified program for spirometry technicians. It is important for a country to have that program, so that the quality of spirometry improves and the diagnosis of COPD gets better across the country. So I think that was a very important message that he conveyed. And then finally, he talked about the importance of a COPD care team, where you need an entire team to actually manage this problem. It's not a problem that can be easily managed by one person. So those were the carry-home messages by Dr. Rajesh. Dr. Pradeep Joshi also gave a very exciting talk about the WHO perspective for India on COPD. He talked about the big programs of tobacco smoking cessation and how successful that has been over the years. He also talked about the non-smoking risk factors and the initiatives that the government and the WHO have undertaken. He talked about Breathe Life campaign, which I thought was very interesting because I had not heard about it before. He also talked about the best buys for tackling non-communicable diseases, where it is important to have an intervention that is affordable to a country, and how work in that area is progressing, so that we could have cost-effective treatments for COPD in our country. He talked about the chest module, which was very new for me as well. Clear Household Energy Solution Toolkit. This is taking into consideration that household air pollution is an important risk factor for COPD. So that was something new that I learned. And then he ended up with all the important policy decisions that the governments have taken on Ujjwala scheme, the international solar, the get together of that, the National Clean Air campaign, and the PMJ campaign, all of which are are directly or indirectly contributing to reducing the burden of COPD from an India WHO perspective. So that was a very good presentation. Dr. Bachani ended up with a very beautiful quote that I'm going to use this in my future talks. Tumhe TB nahi hai. What next? And I think that's a big problem that we are actually facing on a real life basis in our country. We have a very good TB screening program, and once you have been told that you don't have TB, then what? I mean, the patient is just there's a dead end over there. And he talked about the cross referral systems that need to be initiated in our country, and I thought that was a very, very insightful and a brilliant suggestion that he gave. He talked about the importance of the health and the wellness care centers, and especially the linkages between the different healthcare delivery systems was his major focus of presentation. So I think overall it has been a very, very fruitful and a wonderful discussion by all the speakers. And on behalf of IIHM and Indian Association of Respiratory Care, I would like to extend my very sincere thanks to each one of them. I know, Madhura, you have been waiting for a while. Unfortunately, your video did not work when you were invited to speak. So I would give you that 1 minute to speak, and after that, I think Dr. Sandeep Bhatia could offer the vote of thanks.
Yes, Salvi,
Yes,
thank you
Madhura.
so much. It was a brilliant session that we had today, and all the speakers have very nicely put in front of us what is it that we are dealing with and what we should do about it. On behalf of the IARC, I am very grateful to be a part of this webinar. I would just like to add one, in addition to what all we have discussed today, I would just like to add that the qualified, talk about the respiratory therapist. The qualified respiratory therapist with their knowledge of this disease and their skill in aiding diagnosis and evaluation and management of this group of patients in the outpatient settings, the ward, the ICUs at home, in the rehabilitation centers will help in reducing the burden of physicians and also reduce the distress of the patient and the family. And in addition to that, respiratory therapists, I think, can play a key role at the national level and contribute immensely to address the challenges of COPD. If properly and when properly utilized, I think the respiratory therapist will be a great asset to the national healthcare system. So I think with that, I would like to thank you again for allowing me to speak, and I apologize for the technical issues that I faced. Over to you, sir.
Brilliantly put, Madhura. Thank you very much for that. So, Dr. Sandeep, now it's yours.
Sure.
The vote of thanks.
Thank you, Dr. Salvi. Very nice deliberations by all the speakers. So I would like to thank on behalf of IIHD India and IARC. I extend a really hearty vote of thanks to especially our seminar moderator and speaker, Dr. Salvi, who actually spared his time from his busiest schedule to grace this occasion. Today we had an opportunity to hear him out, and this will surely help us and encourage us in our future deliberation. My sincere gratitude to also all the speakers, Dr. Bachani, Dr. Pradeep, Dr. Rajesh, and Dr. Mahesh, for gracing this occasion and sharing their well thought through experiences and learnings today with all of us. I'm sure that these learning will help us who are trying to actually address the issue of prevention and management of COPD. Also, a special mention of Dr. Ruchi, who is the CEO and founder of IIHD, and also Ms. Madhura, Associate Vice President of IIRC, for being catalyst and great support and standing pillar as a strength for us to conduct this event. The event like this cannot happen overnight, and the wheel starts rolling months ago. And we have been very fortunate enough to have a very good back-end team support who actually were very proactive and dedicated to organize this event behind the scenes, especially the technical and social marketing team. Last but not the least, a big thank you to each one of you who made this seminar more memorable and very great experience for all of us. Thank you once again. Thank you all from IIHD and IIRC. Thanks a lot.
Thank you.
Thank you.
Thank you, Dr. Sandeep, and all other
Thanks,
colleagues.
Dr. Bachani.
Thank you.